The SUMMIT trial evaluated long-term effects of tirzepatide in obesity-related HFpEF. Obesity is a major contributor to the development and progression of heart failure with preserved ejection fraction. The expansion and biological transformation of visceral fat leads to the synthesis of adipocytokines and anti-natriuretic and pro-inflammatory effects. This resulting plasma volume expansion and myocardial fibrosis leads simultaneously to an increased filling of the left ventricle and impaired ability of the chamber to tolerate filling, leading to HFpEF. Tirzepatide is a long-acting GIP receptor and GLP-1 receptor agonist, which produces substantial weight loss when given up to 15 milligrams subcutaneous weekly. Tirzepatide results in 12 to 21% of weight loss in patients with obesity. However, its effect in obesity and HFpEF have not been examined. So patients were eligible for the SUMMIT trial if they fulfill the criteria for HFpEF and obesity, requiring an ejection fraction of at least 50%, body mass index of at least 30, and evidence of increased left heart filling pressures. Importantly, there were no minimum NT-proBNP criteria, but they were required to fulfill all three enrichment criteria listed here. These included impaired exercise tolerance, a KCCQ less than 80, and a recent heart failure decompensation or eGFR less than 70. Eligible patients were randomized to tirzepatide or placebo. The initial dose was 2.5 milligrams weekly, up titrated to a target of 15 milligrams. The median follow-up was 104 weeks. There were dual primary endpoints. The outcome was cardiovascular death and worsening heart failure events. KCCQ at 52 weeks was also a core primary endpoint. So 364 patients were randomized to tirzepatide and 367 to placebo. Over 50% of patients were women. The mean proBNP was less than 200. Average eGFR was 65 with a KCCQ of around 53 and a 6-minute walk distance of only around 300 meters. About half had heart failure decompensation within the past 12 months. As you can see, the background therapy was very good. Here are the primary results of the SUMMIT trial. Shown is time to first event for the composite of cardiovascular death and worsening heart failure events. 15.3% of patients in the placebo arm experienced an event. 9.9% of patients in the treatment arm experienced an event. This difference represents a 38% reduction in the risk of a major adverse heart failure outcome in patients randomized to tirzepatide, with a p-value of 0.026. Success of the primary endpoint was primarily driven by reduction in worsening heart failure events, requiring hospitalization or urgent IV drug use for heart failure. A 59% reduction in risk. Of note, there was no effect in all-cause mortality. Now for the other core primary endpoint of KCCQ. When compared with placebo, tirzepatide improved health status by 6.9% at 52 weeks, p-value less than 0.001. This slide shows that there is a consistent effect of tirzepatide for both co-primary endpoints amongst all the subgroups listed here. For key secondary endpoints, there was an 18-meter improvement in the 6-minute walking distance amongst the tirzepatide group. As seen here, body weight was decreased by 11.6% and hs-CRP was reduced by 35%. As expected, the major side effects were related to the gastrointestinal system. This resulted in discontinuing rates of 4.1% in the tirzepatide group. So in conclusion, the SUMMIT trial demonstrated a reduction of the composite of cardiovascular death and worsening heart failure events by 38% with tirzepatide. This was driven by a decreased risk of worsening heart failure events requiring hospitalization or urgent IV drug therapy. It was consistent amongst all predefined subgroups. Tirzepatide also had a meaningful and highly statistical effect to improve KCCQ scores and 6-minute walk distance, as well as reducing systemic inflammation.